Great. Well, thank you very much, Bill, for that introduction and for the plug for mental health first aid training as well. That wasn't expected, but much appreciated. Yes, so here I am this morning. I'm going to, like Bill says, talk about complexity in mental health. So I talked about mental health services, but as you all know, you're all experts in your own fields in the room. You all know that mental health difficulties, diagnosis, things like that affect anybody in any service. Or anybody not in the service as well. So hopefully what I'm talking about is going to speak to all of you from wherever you're working, not just if you're working in, for example, a mental health hospital and things. I'm going to spend a bit of time sort of breaking down what I mean by complex, and I'll get to that in a minute. But first of all, let me just introduce myself a bit further. As Bill said, I'm a psychologist, which means I basically trained and worked in assessing the underlying needs of people who are struggling with difficulties in whatever ways to do with their thoughts and behaviour. And not only that, I work with teams, provide advice on how to support people, how to provide treatment, and also provide treatment myself in terms of individual therapy and group therapy. So Bill mentioned I worked in Broadmoor Hospital. I was there for sort of 8-10 years. Before I went independent, and I used to head up the anger treatment service in Broadmoor, the drug and substance misuse service. And used to work with people with cognitive skills difficulties there. Prior to that, I have spent some time working in the prison service and in community mental health services with people from different ages, children, older adults, some people with learning disabilities, and in a court diversion scheme. So a bit of a range of services and things, so I'm going to draw upon some of my experiences in different ways. Now, just to be a bit more specific what we're going to do, so we're just going to break down this word complex. Okay, it's not an official diagnosis. It's not, you won't be able to find one meaning of it that's shared, unlike the word, for example, anxiety. Just going to break that down. And I'm going to suggest it's very, very simple, so I think simplicity is the key here, approach to working with patients, service users, clients, we use the words interchangeably, for working with complex patients. Okay, so hopefully something that you can take home that will be useful for your settings and where you're working. And from this, I want to sort of just highlight the benefits to yourselves as individuals and to your team, and of course the patients that you're working with. Does anyone mind if patients, clients, service users? No, okay. So first of all, I just want to use some of the expertise in the room here and some of your experiences. Okay, so it's not going to be big, extensive group work. I know I've called it group work, but I'm not going to do that. I just want you to spend sort of up to 5 minutes in your groups just having a think about a patient, a service user, a client that has been particularly difficult to work with. Okay, just that feels difficult. Okay, I'm not going to ask you to define why you felt it was difficult, but I want you to think about what was it about that person or about the situation, or about the team that really struggled with this person. Okay, in whatever definition you feel fits the bill here. Okay, does that make enough sense for now? Okay, and so I'd just like to ask you just to think about that for a few seconds, or up to 5 minutes, and then I'm not going to be able to go around the whole room because I'm sure it'll be very interesting, but it was going to take, probably an hour in itself. Maybe just a few bits of feedback about, if you don't mind, some of those challenges that you faced in your work environments. Will that be okay? Yeah? Okay, so I'll just give you a few minutes to do that. I think that's great that you've all got lots to talk about. Hopefully it was to do with complex presentations, but I won't know. Would anybody be okay in just sharing some of your experiences with the rest of the room? And if you are, put your hands up and someone's going to come over with a microphone for you to ask. Thank you.
Thank you. I'm Julie. I'm from Gloucestershire Hospitals. We're an acute hospital, and hot off the press is that we're experiencing extreme difficulties with a 15-year-old who is on our paediatric ward and being looked after by 5 external RMN nurses. She's autistic, she has challenging behaviours, and she's a self-harmer. So for us, that's a real difficulty because she's not in there for any acute hospital reasons. She's in there as a place of safety. So I call that complex.
Yeah, absolutely. Sounds great. And what are the unusual challenges about this girl for your services that you wouldn't normally expect?
Well, one, the staff aren't geared up to look after a girl with that complex needs.
Yeah.
Two, we use safe holding techniques, and the RMNs use PMVA, and that causes a conflict of interest and obviously a breach of our policy in terms of the techniques and that we use. So for us, it's quite a difficult situation to manage.
Yeah. Absolutely, thank you very much for that. So it's really highlighting the trickiness of working cross services as well and having different approaches and obviously with her individual needs too, but thank you. Anybody else want to share a bit of the discussion or an example? Don't let the microphone put you off. Sorry, could you hold on a moment please, so we can... Great, thank you.
Hi, I'm Jo. I'm from Greater Glasgow and Clyde Health Service in Scotland, and we have, just like the lady was saying earlier, we've had complex situations with patients, and you have safety issues, you have plans in place, you've got registered mental health nurses coming in to help out. We teach the Maybo skills, which are different from what the RMNs are trained on. So it's trying to get compatibility to try and manage situations. We have burnout of staff, who concerns of attribution, you know, the patient knows what they're doing, but, you know, actually there is cognitive issues and stuff going on. So it's actually just trying to get, again, in a general hospital, trying to get some sort of plan in place and let's stick with it. Because if we make it safer, actually that's the same as the lady was saying, it's just a safe approach, you know, because there is nowhere really else this patient can go. You know, so it's with us and it's our responsibility to keep her safe.
Okay, you need everyone to be working together.
Yeah,
you sound
totally.
That's one of the tricky bits at the moment, and yeah, okay, absolutely. Thank you very much for that. Do you have one more? Anybody wants to share from? Things there's some pointing over here somewhere.
Hello, I'm Tricia Pease and I'm the Associate Director for Safeguarding and Mental Health at the Royal Berkshire Hospital in Reading, which is another general hospital, so we've got a bit of a theme going on here. The case we shared was actually another 15-year-old, but our problems are not just in paediatrics. So we had a girl that was in our paediatric ward for a week. We had to restrain her on several occasions. She was chemically as well as physically restrained. She ran amok through the wards. We had to keep her there because she tried to throw herself in front of a car while she was with us. She didn't have a diagnosis of any sort at this point. She's got a behavioural disorder, but no diagnosis. Very challenging. She was a serial self-harmer. So we're seeing this across the way. But actually in our hospital, in our elderly care wards, we're having similar situations. Eating disorder patients, we're having a real rise in eating disorder patients that can't move on to specialist beds. So if I looked across my trust and our neurodisability wards, that's more challenging as well. So whichever area I look at, our patients have got more physical health needs and psychosocial health needs. We get people coming in who are homeless or they've got drug habits as well. So it's not in any one age group and it's not in any one service, it's across our patch.
Okay, that's a nice way of summing it up.
That's
actually,
complexity.
As well. That is complexity, yes. And again, it's across all services, age groups, and you just highlighted some examples of different types of needs as well: eating disorder, self-harm, suicide attempts, a sort of variety. So this is, very interesting. So I think I'm in the right place talking about this stuff, and I'm really pleased to see that some of these examples are on something I'm going to talk about in a minute. But let's start with the sort of premise that this is sort of my belief, right? So if we can identify these complex patients early on, and we understand this complexity, we understand the whole patient, we're going to be able to engage them a lot better, okay? And as a team, we're going to work a lot better with them, okay? So we're going to apply a very simple approach to this. You might be doing it already, which would be wonderful. But I believe we apply the simple approach, we're going to get a better outcome for the patients, for yourselves as individuals, and for the teams that you're working with. Okay, so this is my belief. Let me start by using one of my examples, if that's okay, because I'm going to talk through this example of John. He's a real patient. That's not his real name, clearly. And just the reason I want to talk about John is because I want to just highlight how many of these issues sort of can be present in one person. I have admittedly picked one of the worst patients in terms of complexity that I've worked with, but he does sort of illustrate many of the factors that I'm going to be talking about. And then later on towards the end, I'm going to tell you a bit about what happened with John in the end and how we approached it. Okay, so I hope this brings it to life a bit for you as well. Okay, so John had a very unfortunate start in life in that he didn't really know we certainly didn't know his father at all. He was taken out of the care of his mother at a very, very young age. She couldn't care for him. She had her own difficulties around substances and alcohol use, and wasn't able to look after him very well. He was put into a children's home. Unfortunately, it was one of the children's home where the care was abusive in all sorts of ways. So there was lots of physical abuse, sexual abuse, neglect, and just general, poor care of all the children. His behaviour, as you might expect, deteriorated very rapidly in terms of, not receiving that care that he required. He became very violent in particular. So I'm talking about the age of 6, stabbing other children, bashing their heads against basins in bathrooms, things like that. It became to be feared by other children as well. He often would run away, including overnight, and he'd get on the trains and he'd end up in all sorts of parts of the country. He eventually was placed in a foster family. Unfortunately, that didn't necessarily go much better because there was a sort of a kind mother figure, the father figure was also abusive towards John and would beat him regularly. So in terms of John feeling safe and secure, he didn't. Okay, a sort of really mixed care, and the sort of personality was already being laid down by his early years. Again, he ran away and eventually was old enough for nobody to bother trying to bring him back. He lived on the streets, committed burglaries, things like that to survive, lived as a rent boy, and spent much time with the gay community as well. Now, it wasn't too long, I think he was about 18, 19 before he committed his index offence. Okay, so he strangled 2 men in their apartment one night and was arrested for this crime and was found to have committed it and was given a hospital order as his sentence. Okay, so he was put in a high secure hospital for an indefinite period of time because he needed treatment for his mental disorder. So he's detained under Section 37 of the Mental Health Act. What was his mental disorder? Well, he had a multiple diagnosis of personality disorder. Okay, so I'm going to go through this in a bit more detail later because personality disorder or personality dysfunction can feature anywhere in community or different settings. Okay, so he had an antisocial personality disorder in particular, and if you went through the assessment, we found out he would meet the criteria for being a psychopath as well. Okay, so here he is here's the hospital, it's not him. So what happened when he was in this hospital? So by the time I started working with him, I think he'd already been there at least 8 years. The average stay at the hospital was 7. He was repeatedly moved from ward to ward after about 1.5 years because what he would do is he'd settle onto a new ward and think everything's lovely. I've got a brand new team. We're going to have some fresh, we're going to get on really well. They're going to help me and everything's going to be lovely. But sort of after a bit of time, the rosy start sort of changed, and he'd become very abusive towards other staff members. He'd be blaming them for anything that went wrong, even if it was not their fault. He'd pick up on the slightest issues, such as medication being 1 minute late that day. He would be very violent and aggressive towards other patients as well. On a number of occasions, he attacked other patients, and on 2 different situations, he tried to strangle other patients. So he was also often moved for that reason. Okay, so when he came onto the ward I was working on, again, nice rosy start, lovely one-to-one sessions with him as a psychologist. We went through the assessment, things like that. But again, the same behaviours emerged, and the staff started to feel really tired of him, really tired, did not want to spend any more time with him than they had to. And in fact, they didn't even, they'd probably try and find a reason to do paperwork rather than spend time on the ward talking to him. He would yell at them. He would put in complaint after complaint after complaint. And there was a real rejection towards him, with the staff feeling very angry at his behaviour, particularly if somebody was suspended or investigated because they were being, for the complaints that he would put in. And of course, the other thing he would do is something called splitting. So he would treat different people in different ways. So some staff would be absolutely fantastic. They're amazing. Other staff would just be, the worst possible, and he would almost play them off against each other. So you didn't kind of know what you were getting. And if you were one of the ones that he was targeting, then you had a really difficult shift at work. Okay. So that's John. Now, I think he ticks a lot of these boxes. So these are what I'm proposing are the types of things that make somebody complex. Okay, and the people that gave that feedback just now from your group discussions already mentioned some of these things. Okay, so it's going to go around. So multiple diagnosis, I will come back to this. And I'm talking about in any sense. So having more than one diagnosis. So we could be talking about a mental health disorder like anxiety or depression, but perhaps someone with a learning disability, autism, or someone with a physical disorder as well, that adds to the complexity of care, might make medication, for example, more difficult. Somebody with a personality sort of features as well. So, as I said, I'll come back to that. Now, what about someone in crisis? So, again, mention of that, somebody who attempts to take their life, who is self-harming, who is sort of actively psychotic, hallucinating, under delusions, or under sort of heavy influence of alcohol and substances. They're going to be difficult to engage or see more complex because you probably have to deal with the crisis first, and it gets in the way of everyday treatment. Distorted reality, again, so someone who's got a visual hallucination or hearing something that's not there as well. Again, the difficulties around engaging them. Tried sort of doing a sort of a one-to-one assessment of somebody who is, hearing something else that's not really in the room. Personality disorder. I'm going to come back to personality disorder. Somebody with a history of trauma. I know we're going to have I'm sure an interesting talk later about trauma. Some people lived with trauma, but 85% of adults with complex needs have experienced a childhood trauma. Okay, so it's fairly common, and the relationship between experiences later is clearly there. Okay, so this could just be, parental violence, addiction, being abused, starvation, experiencing mental health issues in younger years or from their parents. Okay. Not react as expected. Does anybody think, hang on, I thought this patient was meant to be getting better, or respond positively to the care I'm showing, and yet that doesn't seem to happen? Has anyone felt? So I'm talking about the sort of individuals who seem to reject the help that's being offered, don't seem to want it, sort of throw it back in your face, or you think they should be getting better, but actually, and they're just about to move on in a really positive way, something positive is about to happen, and they seem to do something to prevent that happening and just take a massive step backwards. So it's just that anticipation of moving on, getting better, and maybe there's a fear around that as well. So just difficult reactions, which make it very difficult, I think, for a member of staff. If you sort of don't know what they're going to say, what they're going to do, and they can sort of act in the complete opposite way than what you think they should. Poor resources, again, in the broadest sort of definition of the extent of that. So in terms of having poor coping strategies is something we learn as we grow up by seeing our parents have good coping strategies, learning from others, learning from school, things like that. Something we can learn in later life too, which is great in terms of helping our sort of service users. But not everybody has good coping strategies. But also sort of mental health complexity is related with people who live alone, more increased levels of poverty, poor physical health, unemployment, things like that. Okay, and then the other one, obviously, alcohol and substance misuse alongside. So some, highlighted difficulties of cross-service working, but if somebody's got a alcohol and substance misuse problem, they might fall under those services as well, and there might be some necessity to work with those services, but also, it might influence their medication or their ability to turn up for sessions, or it depends on the layout of the service. Okay, so that's sort of a broad brush of what I mean by complexity. So, like I said, I'm going to come back to multiple diagnosis. Okay, so there's a well-known statistic that you might have heard already, but if we say 1 in 4 people in their lifetime is going to suffer from a mental health disorder, okay, diagnosable disorder. Right, not necessarily all will be diagnosed and all will seek help, but that's sort of the extent of that. 1 in 6 people any one time will have some sort of mental health difficulties. Now, if we take the other fact that 50% of people aged 16 to 64 who do have one of the common mental health disorders also have depression or anxiety at the same time. Okay, so we're talking, I don't know how you work that out as overall, but if you said 1 in 6 at any one time, and then half of those, or 1 in 12 therefore, will have no, it's not all right, but will have 2 mental disorders at one time. Somebody worked that out, the numbers, 3 out of 6. So almost comorbidity or multiple diagnosis becomes the norm, really. Anyone trained in sort of doing therapy or something for treatment for anxiety, the book says, you have anxiety, this is what you do. There's not as many manuals that say, you've got anxiety, but also you're suffering from a psychotic disorder and you use alcohol to cope, this is what you do. You don't get many manuals that will tell you that. You've got to figure it out yourselves and figure it out with the services and the restraints that you're working with. So it also means that in your assessments or understanding your patients, you can't stop at the first presenting problem. That seems to be the case. Okay, so somebody might appear that having a learning disability is their main issue, to put it one way, or that they are suffering from schizophrenia. You can't stop there. You need to go through everything else and ask about everything else. Anxiety, depression, how do they cope, what do they do, things like that. Okay, and it will have treatment impacts as well, so that's another reason why. Okay, I'm going to move on to personality disorder. Has anyone worked with people with personality disorder here? No, really? Okay, good, a few handful. Now, another statistic is 1 in 10 people in the population would meet the criteria for a personality disorder, even if they don't realise it and haven't been diagnosed. Okay, so that's on a sort of national survey by the Mental Health Foundation, just asking people to basically send back information about how they feel and how they think and how they act in certain situations. So they're not saying, I have a personality disorder, but they're showing the symptoms, and that's how this statistic was put together. So the chances are every single one of you actually has come across somebody with a personality disorder, or at least sort of certain personality dysfunctions. And often those people that might seem more complicated or don't react in the way you expect them to, for example, that might be just an aspect of their personality that is making those interactions just a bit more difficult. Okay, so what is a personality disorder? So our personality is an underlying pattern that we've sort of grown up with from childhood, okay? So when that personality in that personality, you have a particular pattern of the way you think, the way you interpret events, the way you understand your own feelings, and the way you understand the feelings of other people and interpret those, and the way you relate to people. Okay, so kind of as a pattern. Now, when those thinking, emotions, feelings, behaviours start to go beyond the realm of what would most people consider normal, then you start looking at the realms of a personality disorder. So your extreme behaviours, your extreme emotional fluctuations, for example, your distorted thinking, that you just think, how did you come to that conclusion from that? This is sort of the pattern, the way they're thinking. So there are I don't know if you know, up to 10 types of personality disorder. I'm not going to go through 10 types of personality disorder, but the most common one, I'll just go through 2, is antisocial personality disorder. Okay, so this is surveyed to affect 3.3% of the population, 3 times more men than women. So what is it? It's a disregard for social obligations, the norms, a callous concern for the feelings of other people, so really not caring, no empathy, and that this behaviour and acting is not modifiable from adverse experiences. So if you punish someone like that, you lock them up, they're not going to learn from being punished and locked up. It's not going to change their behaviour. This behaviour is ingrained. Low tolerance to frustration, easily aggressive and violent. And when you start talking to them about this behaviour, they've got there's an easy blame for someone else as an explanation as to why that occurred, or a rationalisation around it. Okay. Does that sound familiar to anybody? Just come across? Yeah? Okay, and then the other main one that people usually have come across is borderline personality disorder, also known as emotionally unstable personality disorder. This isn't necessarily, obviously, as linked with violence or forensic issues. This is 2.4% of the population. So in this, it's more about the person's internal personal distress. Great difficulty in understanding their emotions, in regulating their emotions. Emotions can change very quickly, literally split second by split second, go from happy to sad to confused, or at some moments to feeling just completely empty and having no emotions at all. Okay, which is very upsetting. Okay, rather than a sort of ambivalence. Very poor sense of self, very poor sense of their own identity, and that can change all the time. So using John's example, I didn't mention that he changed his name 3 times in 3 years by deed poll. Imagine changing your name that frequently. He changed his sexuality, and he changed his religion frequently as well. He didn't really know who he was and who he wanted to be. And often in terms of managing this internal distress, there's a relationship with self-harm behaviour with people with bipolar personality disorder. Sorry, not borderline personality disorder. Okay, so one of the ways, if you're thinking, is somebody I know who seems difficult, could they be sort of suffering or meeting the criteria for personality disorder? This is the test, really, the 3 Ps. Okay, is the behaviour, thinking, feeling problematic? All right, out of the realms of normality or beyond. Is it persistent? So personality disorder has to have started in late adolescence or early adulthood and persist throughout the person's adulthood. Now, fortunately, something like antisocial personality disorder starts to burn out a little bit around the 60s. Okay, you don't, but it's persistent and pervasive. So not just in one setting, okay, not just when the person's at college or something like that, or at work. You know, you're going to attribute that to more something situational, but this is pervasive across every aspect, family life, friends, things like that. Okay, so the 3 Ps in relation to personality disorder. Right, now I'm going to give you what is my very simple approach to working with people with complex difficulties. And it's simple on purpose. Okay, so first of all, we need to understand your client. Okay, this sounds like lesson 1 of college, but I'll get into what I mean in a bit more detail. Okay, then think about the team's response. And I think this is actually the difficult bit sometimes. Okay, and I think that will just lead to better care for the others, for your patients, and for yourselves. All right, so understanding your client. Okay, so what I'm talking about is a thorough multidisciplinary assessment. You probably think, we do that, which is great. I hope you do. Okay, so this is in terms of what is the person presenting with when they come to your service, they come and see you. What are their complaints? What are their symptoms? What diagnosis do they have already? Have there been any particular incidences? How are they behaving? Have they been transferred from another service? Have they been found too difficult to work with or not fit somewhere else? some forensic issues going on. So what is that person like right there and then? Are they in a crisis? Are they a risk to themselves, a risk to other people, under the influence of alcohol or substances? What's their personality like? How do they relate to other people? How do they respond to care and services? Okay, then your background. So if you want to know what has gone well with somebody before or what helps them, then we need to know what they've done before, what kind of care they've had before, what kind of support do they find the most helpful, not helpful, do they get passed on from service to service very quickly, have they grown up in a stable environment, are those kind of core personality needs or cognitive needs met in early childhood, how well functioning are they as individuals, things like that. Do they have family around them, do they have support in their community, do they have is there a key worker that they've got on really well with that they've had for years, things like that. What other struggles do they have in their everyday life around housing, employment, money, things like that. Okay, so it's a full understanding of the person. Now, I think we do that a lot already, okay, but what I don't think we necessarily do, or certainly, okay, we'll say, in my experience, this has not necessarily happened the next step, which is to put together the formulation. Okay, what I mean by formulation is the story or the understanding of what that person has grown up with, what's happened to them, and how they are the person that they are today. Okay, how does all that fit together? Why are they presenting as they present? So it's the difference between having a patient who is verbally aggressive towards you and you thinking, right, so what I need to do now is stop them shouting and stop them abusing me or members of staff, and I'm going to care plan that and tell them to stop doing it. Versus with a formulation and understanding, think, right, okay, I understand what this person has grown up with, what's happened to them in the past, and I understand that when this person's shouting at me, what they're actually trying to do is deal with the fear and the anxiety inside them that I am beginning to get too close to them and understand them and help them. Because they've never had help before and they want to reject that help. That's really uncomfortable. They don't know where they are with that. And I would probably go about treating that or helping that in a very different way if I had that understanding. So that's what I mean by a formulation, by bringing everything together and having a true understanding of that patient in all that complexity. I hope I'm making sense. Yeah. Okay, right, so what do we do with it after that? Okay, so this is when I think working together as a team has its real strengths, and I know it's got its difficulties with the challenges of running around having to do two people's job at once and teams not being on the same shifts and things like that. But I think a team response is definitely the way forward. We need everybody who's working with that patient to have the same shared understanding, okay, the same approach. So again, if one person is trying to stop that person shouting and yelling, and that's their primary goal, versus somebody else is working with the sort of thinking about their sort of fear about being helped, it's going to feel like inconsistent care. But what we need is consistent care. Okay, so it's about sharing that model of formulation. Now, very frequently, this is done by somebody writing the formulation, like psychologists, and it goes in the patient's files, and it sits there. Maybe the primary nurse will read it or the care coordinator will read it, but I really struggle to think how somebody who's coming onto their shift, which is going to be really busy, is going to get enough time off the shop floor to go and sit and open up a folder and read a report. That's just not reality, is it? So we need to find ways of sharing these formulations and get everyone thinking the same. I think it will give people clarity about their roles as well. What exactly am I going to be doing and saying to this patient with this understanding? It will give consistency towards the patient. Also, something else I think is quite important is, ultimately there's going to be somebody responsible for making a risk assessment and the management, but I think the more people that contribute to that discussion, if possible, the better. You're going to get a decision made not so much on an emotional reaction to something that's happened, but perhaps a clear thought and analysis and using the formulation to make that risk assessment. And we need to create thinking space. I'm going to come back to that in a minute. Again, it sounds like a luxury in press services today, but hugely important and worthwhile investment if we can. Okay, so how is this going to help? So this is in terms of our patients. So again, so we're going to be doing our care plans or our approaches to the patients in an informed way based on the formulation, based on our full understanding of this person. The care will be planned. We know what we're going to be doing in advance rather than reacting to a crisis or a situation. Evidence-based, so use your literature of what works, things like that, experience as well. In this way, we can also make the treatment plan personal. Okay, so not I've got one already here to manage somebody who's self-harming, dig it out the file and apply it to the next person, but something that's very specific and personal. Okay, and again, it's got to be acted upon in a very consistent way by the whole team and reviewed. Okay, but we mustn't forget the care for yourselves or for the people on the front line. Okay, patients with complex needs are very difficult to work with. Somebody used the word burnout earlier when they were describing one of their own patients, and that's a real threat, I think. I mean, the NHS and other services are already stretched as it is, and then you get a patient who's shouting at you all day long, who doesn't seem to be responding to care. You put your soul into that 8-hour shift to support them, and the next day they seem to have gone backwards 10 steps. It's really hard work, and you do need support and to think about what is going on, understanding. So obviously supervision, support and training, so knowing more about these issues, particularly when it comes, well, my service was a personality disorder service, and we trained all the staff in personality disorder before they started working in the wards, and yet you get there and you meet the real patients and it all goes out the window and you forget everything, or it's not enough. It's only when you really meet somebody face to face you understand actually what's going on, and then you can start talking about what it's like to work with them and to learn from experiences, discuss things with each other. Now, our own reactions and defences. So this is going to be a bit of a common thing to say, but people do experience it, and I think probably find it hard sometimes to talk about it. But sometimes we can have quite negative reactions towards our patients. Okay, I certainly didn't look forward to seeing John. I mean, I admit that very, very readily, but I had to. He was my patient, and I had to think about what was going on for him. So we might forget about patients, or we're just reluctant to engage with them. Might feel overwhelmed by them, and certainly less sympathetic towards them. On the other hand, you can, I've seen it in staff members, you might feel, you might give special treatment to someone, actually. So I don't want them to yell at me. All they want is for me to go and get this thing that they're not particularly loud at this time of day. But you know what? If I go and get it, they're going to be a lot happier. My shift's going to be a lot more peaceful, and everything will be okay. And I'm going to go and do that thing for that person, or make that call for them, or whatever it is. Okay, so you've got to be really careful about these special treatments as well. And what do we do this for? Well, one easy shift, we think we're helping the person, but also it's about our own defences. Okay, we're all humans as well. We have our own emotions, feelings, and baggage from the past as well. Okay, so maybe we're protecting ourselves too, cutting ourselves off from, things that might remind us from difficult situations. Maybe we need breather time. Maybe we're going to go and do our paperwork rather than spend more time talking to the person on the ward. We might just feel hopeless. We don't know what we're doing, and need support with that as well. So we need to be really thoughtful, I think, about our own reactions, our defences, and how we manage those. I think it's also good to be realistic about change and expectations. I think it leads to a healthier outlook on our patients. I'm not saying that they don't, if they're not going to change quickly, we don't expect them to change quickly. That's okay. That might be about the complexity of their needs and what service can provide. But expecting them to change because you've had a great 2-hour session with them, this is going to make you feel deflated and not necessarily want to go and do it again. But it's about being realistic and taking time to notice the positive changes and experiences that have happened, being very important. sort of alluded to your roles and responsibilities. So it's carrying them out in accordance with the planned care based on the formulation. Okay, and sticking with that. Now, that's a nice sort of framework, I think, sort of puts into 4 easy steps. Let me go back to John, if I can, and sort of say what we did with him. So we had John, as I said, he was being very difficult, and it wasn't enough what people already knew about personality disorder or knew a bit about his background. So being the one who was his psychologist and did his assessment, I put together just literally some presentations about John, and I would grab nursing handovers and get the members of staff there, as many as possible, and do it repeatedly until I covered everybody. I'd go through John's background. And even though he'd been on the ward for a while and people knew about things, there were lots of things that people hadn't had a chance to look into or hadn't had a chance to read about. And I would share the formulation about John in a way that is, accessible to people working on the ward. And people started to understand where his behaviour was coming from. And we talked about looking at his care plans again and started making them really personal. And also the staff from the ward and myself, we started going through some of these new care plans in a lot more detail with John himself. So he started to recognise where we were coming from. That in itself didn't make it easier for him to control his emotions, for example, things like that, but he started to understand why his emotions fluctuated as quickly as they did. He started to realise the correlation between his emotion changing and actually what the trigger was and what kind of triggers there were. And he could start to identify some of these patterns as well. And it's only when he started to understand himself that he could start making changes or ask for help. Now, one of the other things we decided to do with John was actually to not move him again. So, like I said, he'd been moved many times before, and that was his way of not getting close to a team, not being cared for, and be able to start again fresh with that smiley John that starts in the new ward. He'd got to that point on our ward where he had ruined all his relationships with staff members and with other patients, and he was very frustrated and just wanting to move on. And it was around the time we started doing this work, we actually made the decision we're not going to move him on. So what we were telling John was, it's a bit like you're telling a child, no matter what you do, I love you unconditionally. Okay, so John, no matter what you do, we are going to be the team that look after you. Okay, because we're going to work through this with you, we're going to understand you, and we're going to protect you as well as ourselves. And we're going to get through to the other side in a way that's a lot more positive than it would have been if we just moved you on and mirrored another rejection and abandonment. So he found that very difficult, and he started to display slightly different behaviours. What we understood by these behaviours from having done the assessment and created the formulation was that these were the behaviours he showed right before an attack on somebody else. Like I said, some of these have been very serious, like attempted strangulations. So we took a pretty unusual step in that we secluded him. And of course we had to justify this to his lawyers. But we secluded him because we had so much evidence that he was imminently about to be violent and therefore a risk to somebody else. Now, he obviously was very angry at this because he saw this as completely unjustified and he hadn't done anything violent yet. And we'd meet with him regularly, talk with him, try and help him understand what we were observing, help him understand what had happened in the past, what this pattern was that was replaying again and again. And that we were going to break this pattern. We weren't going to let this violent incident take place. He did eventually understand and come to appreciate that, and after 10 days, we let him out. And of course, he wasn't a model patient after that, or a model citizen, but he was a lot better. He started to realise that we understood him and that we knew or we could help him and help him to feel supported. Now, this is not a miracle, but eventually he got better and he went on to a less intensive ward and then into a less intensive hospital after that as well. And after that, I don't know what's happened to him, unfortunately. But hopefully it's positive. Okay. So that was John, and that's sort of showing you how things can be different and how we can get through this complexity. All right, so it's a summary. I've only just said it 10 minutes ago, so hopefully it's fresh already, but a thorough assessment, multidisciplinary assessment, leading to a formulation. This is what's key, a thorough understanding. Okay, responding as a team, sharing that understanding, and doing personalised treatment. Okay, the other big things about reflecting and providing your own support. Okay, for your own mental health and for the actual care for the patient as well. Okay, those are my key tips. Right, and I haven't overrun actually. All right, any questions? Oh dear. And I guess we're waiting for the microphone again, are we? Okay.
Hi Paula, I'm Matt from Maybo and have a background within secure mental health services. I think that was a really interesting talk, thank you for that, with bringing up, going back to John talking about staff were pressed, staff were getting very stressed and difficult working with him. And I know you mentioned a couple of times about in that model as well around the patient in the middle and the complex needs. I think often you can put staff in the middle of that and look at poor coping strategies of what staff have. With training, and I know you said about supervision, support and training for staff, is there anything that we can offer training-wise for staff that isn't about working with complex needs about the other person, but about what can we do for ourselves? How do we manage ourselves to make sure, essentially around how can we increase our tolerance for staff and working in those environments? Because all those key bits of training we can apply if we're in the right frame of mind. So anything through your experience you found that how can we help staff help service users?
Okay, so so there's general training you can do about improving general mental health of somebody, so that'd be about increasing somebody's resilience. So, tips like being, more mindful in the moment, taking notice, not rushing around every day, being more active in your day-to-day life, perhaps engaging in something outside of work, having another hobby or distraction, using support from other people, family, friends, things like that. Also in terms of giving, we find that improves people's mental health as well, whether it's giving time or giving to charity, things like that. So you can, and those are just examples, so you can train people generally to have better mental health and feel more positive, and then hopefully take that into their work environment. Is that the kind of thing you mean, or did you mean actual skills in communicating with someone who's shouting at you, for example?
I think it's that because we often we talk about looking after yourself and the importance with that, and having a family support network at home, hobbies. But what can we do? Like we're in pressed environments where staff are day in, day out dealing with serious, challenging behaviour. What can we offer them training-wise that is about how do we support people working in those environments? How do we try to avoid burnout? Out from because we all talk about what can you do at home, and I think that's something that if people do it, they do it and they believe in it. But I think that's a real challenge in helping staff, help people, and practical ways, emotional well-being, having good mental health. But it's just really...
Yeah, no, absolutely. I think it's, if we could all put a lot more funding into services and let people take time off and shifts and have a long break as well, I mean, those things would be great, but it's not always practical, is it? But I think, some of the literature, some of the core things associated with sort of better mental health at work include feeling more empowered, feeling you have more autonomy in your role, feeling like you're part of the decision-making of what's going on, being consulted, things like that. Having supervisors or leaders that are quite open to talking about some mental health difficulties and raising the subject of how you're coping and how stressful you're feeling. And sometimes, it's easy enough to say this, but it requires a cultural change. Sometimes for people to feel that they can go to their supervisors and have those conversations. But when they can, it makes a huge difference. Yeah.
Thank you.
All right. questions? Yep, there's one here at the front.
Hi, Paola. Just moving on from that, looking at that same issue from a different angle. We did some training in some secure settings, forensic settings, and what we found was as much as support, challenging the staff as well. So there was like an implicit bias. We were talking about on our table about a transference, and specifically around sort of personality disorders, where people didn't see it as a. So this was for staff not seeing it as a genuine diagnosis. So they got the bipolar, but it was like they're spoiled, manipulative, and we had to really kind of look at exercises to get them to understand the trauma and to kind of to sort of almost challenge themselves to think, okay, yeah, maybe I'm not. There is mindfulness. Getting to appreciate, and it's something that we built. That's built into the Maybo program. And from what I've gathered from other services, that's quite common with personality disorders. Any sort of tips, or is that something that you'd say we need to do to sort of challenge staff's implicit bias that they might have?
Yeah, no, absolutely, and I think that is so common. That is the reaction to somebody with personality disorder. I think we all have our own beliefs, or how people should behave, and when somebody is acting in a way that's contrary to that because they're more aggressive, more rejecting, more abusive, then it can really get to us because, well, then no, that's wrong. I shouldn't. I'm coming here to work with you, and I'm probably not being paid enough to tolerate this verbal aggression, yet you're yelling at me. And it's a natural human response. Like you said, transference and counter-transference are at play. And I think you've highlighted exactly the way to approach that is to have that self-reflection and to support people with that. And actually just to first of all start by saying this is normal. There's nothing wrong with you. You're a very caring staff member here. This is a very normal reaction you're having. What we need to do is sit down and understand this reaction and feel actually as a team it's okay to talk about it. Because if I'm feeling it, you're probably feeling it as well. And this is not about a problem and us. This is about what is well documented as a normal reaction to this kind of behaviour from somebody with personality disorder. And I think just starting to understand that, this is normal. You're not the only people, and it's about reflecting on it and thinking, having that understanding with the education, like you're saying. Yeah.
Thank you.
Thank you. Okay, there's no more questions now. As Bill said, we can have questions late. Oh, sorry. Yep.
Sorry, this is just carrying on. My name's Kate Egginton, Associate Director of Nursing at the Royal Berkshire. Carrying on from your comments, the example that we gave was similar to the lady over here, was a 15-year-old who presented with many of the complexities we've described. But actually when we started to try and understand where it came from, there wasn't an obvious adverse childhood event. And then everyone just kind of stopped talking. We didn't quite know, in terms of exploring and trying to understand, we kind of hit a dead end. We weren't really sure. So I guess my question is there a process within the judicial system and also within mental health services that makes provision for that? And is there something around, if somebody does present with these sorts of complexities, actually looking back and having a high index of suspicion of an adverse childhood event or a previous trauma that you can then sort of explore further? Because there wasn't anything obvious, and actually we started to get suspicious that there might have been that she hadn't disclosed yet. And then what do we do? We didn't know.
Okay. So the first question around, is there a judicial process to uncover that? Or?
Okay, so what do we do?
Yeah.
How do we protect that young person when we're presented with something where we have a high index of suspicion of an adverse childhood event, but yet there's no evidence for it? We started to then be suspicious that there might have been that she hadn't disclosed, and we didn't know what to do. We were very concerned that there may have been something going on, but we didn't know what to do. But so what do we do? Can you provide some tips about where we can go and basically fix our problems for us? Thank you.
And you mean from a management point of view or a treatment point of view?
A treatment point of view, not a management point of view.
Okay, so the ins and outs of how you can investigate this for a 15-year-old, I don't know, against their will and dig up records and things like that. That's probably not the primary question, is it? But can you investigate it?
Because I worked alongside Kate with this case, and with I'm the Associate Director of Nursing for Safeguarding and Mental Health.
Yeah.
So safeguarding comes under me, and therefore it was looked at in a safeguarding way.
Yeah. Okay.
And I sat the night before this young woman left and talked to her mother about the 5 years of the way agencies hadn't worked with this family, and they hadn't worked with this girl, and she'd been put in wrong settings. And her mother had been party to the local authority and the local CAMS provider arguing about funding. So from my perspective, you talked about complexity in terms of when people have diagnoses. And I believe the problem with this young woman was she was seen too simply at the beginning. So 5 years before, she'd been seen in a very simplistic way. And I've seen it again and again with this sort of young person, that they may be put on an eating disorder pathway. They may have features of an eating disorder, but they're much more complex than that. I think one of the issues is, especially with young people, we don't recognise complexity soon enough, and we try and simplify it, and we push them down pathways. And I think that's what was going on. It was interesting because it took a judge to get this girl out of our hospital. So there's our judicial process.
Right,
She was made a ward of court. The solution when she first arrived, that she was going to a secure unit in Scotland. She was going to be sent to you up in Scotland. The reality was the judge banged a few heads together and insisted that she have two things done: a mental capacity assessment and proper engagement. She was actually discharged from our ward to home with a community package she wasn't put into. So I think it's something about the services we offer as well as the complexity of the child.
Yeah.
Does that sound familiar to people?
Yeah. And
I don't think it's as simple as, could you offer us a solution? I really don't, because I don't think that the services that we're offering, particularly children, are appropriate and adequate at the moment.
yeah. And it sounds like what you're saying as well, they have to be too pigeonholed.
They are too
Rather
pigeonholed,
than
and that's what I've seen.
understanding.
She's not the only girl. We've done a big audit of cases of her nature in our patch, quite a detailed audit of 12, and that's what we've seen again and again, is that the services we provide are not able to do what you were talking about there. Until we don't do it until it becomes the crisis. We don't do it soon enough. Does that make sense?
Yeah, absolutely. And in answer to sort of part of the first question around what we do treatment-wise, if you don't have, or you suspect you don't have the full information about something that's happened early on, is you can still work with the person without that information, because what you are looking at with how they present today is for example, their understanding of the world. You know, how do they perceive the world? Their relationships with the mother, the family, things like that. How they interact with others, and you're going to have difficult there if she's been in and out of services for 5 years. So, you know, in some of her formative years. But it's about just really getting to the depths of how they are today and how they perceive the world. I mean, I had another patient who went on to, it's quite specific to this forensic service, but went on to commit many rapes. And going through his early background, there was hardly anything that seemed out of sorts. A episode of abuse, but it didn't seem to answer all the questions. But nevertheless, upon assessing him, you could understand the way he framed interactions with other people and his needs, and how he thought he was okay to go and meet those needs, were very distorted compared to an average person. So even though I couldn't quite work out what else might have triggered his personality as it was and his behaviour, I could still understand that behaviour in the present. Yeah. Okay. Thank you. No. Well, I'm available in the breaks if you want to come and catch me with anything else you think of, or if there's any time for questions later, we could do that. But I just want to say thank you very much for your engagement, your interest, and for sharing some of your experiences and clients as well. It's been really useful to hear about those too, and to bring it all to life more as well. So thank you very much.